Like on certain days, you'll have to be on call, post call into clinic, and then well, post call rounds into clinic and so on. So it'd be pretty hard. Fortunately, I didn't have clinic, but definitely working post call. Whoever came up with the idea of call, right, for doctors is a terrible, terrible idea. Is absolutely one of the worst humanly conceivable ideas ever in the history of mankind in any profession. If someone has to work for 24 hours, that is a terrible idea. 10 out of 10, do not recommend it. I don't know whose idea that was. There are other professions required to work 24 hours, and it's a terrible idea there. It's an absolutely terrible idea in medicine, right? I am 100% for changing that notion of 24-hour calls. I don't think it's a good idea. Hopefully, one day I get in that position or have my own place where people are not required to work 24-hour calls. That being said, I do enjoy call. It's a lot you learn and it's fast paced, and that's why I chose internal medicine over surgery because of the high yield critical thinking that is required in such a short period of time. But it's like yeah. As a student, I used to do 24 as well in certain rotations. Obs and gyne, I would do 24. But like when you're working is obviously different to being a student because when you're working, you're literally working, right? So soak it up as a student and they say it is build your back. So you get acclimatized and accustomed to these ridiculous hours and unreasonable time frames. Um, so I was on call yesterday and I saw this patient, very interesting. I was on call for another consultant, but that consultant is also a neurologist, but he was covering the internal medicine call. So the registrar was also a neurologist. So I called her because I was kind of confused about what to do, or how to treat it. So this 59-year-old female presented. She has a known history of multiple myeloma diagnosed in 2023 in Florida or something like that. Never received treatment for it. And she presented with this sudden onset of decreased responsiveness. Now, decreased responsiveness is a one of the most common presentations in an accident and emergency setting on call for internal medicine, right? So obviously you're thinking things like stroke, hypoglycemia, etc. So you always have to do a CT scan, you always have to check the blood sugar and etc. But before we get to that, she has this history of Parkinsonism, right? For which she's on L-dopa, carbidopa, right? And when we do neuro, we'll talk a little bit about Parkinson's and the treatment and so on. But she came in for this decreased responsiveness and this sudden increase in rigidity um, that presented as weakness and hypertonicity, I guess, because when the accident and emergency referred it to me, I got it as a rule out stroke, rule out cerebrovascular accident kind of picture with a sepsis query source, and her hemoglobin was 7.9, right? So that's how I got the referral. The white cell was 12.8 and she had a fever to 38.4 with a pulse of 109. So it kind of looked like a septic picture. So any patient, especially elderly, she was 69, not 59, especially elderly, who comes in with decreased responsiveness and fever, stiffness, is two things you have to think about all the time: cerebrovascular accident or sepsis, because sepsis oftentimes presents with very similarly in terms of confusion and all of that in the elderly. And she did have a fever, with a mildly elevated white cell count. Now, she had no infective source, right? We did a urine dipstick and her leukocytes, nitrites were negative. Um, we pulled blood cultures. Of course, that will take some time to get back the results, but I wasn't completely convinced that the fever was because of sepsis because she had no cough, she had no urinary symptoms. She was alert and oriented to person and place, but not to time. So her GCS was about 14 on 15. So the quote unquote weakness was not unilateral, and she had no other focal deficits. She didn't have any facial drooping. Cranial nerves 1 to 12 were intact. And I just wasn't convinced that it was a cerebrovascular accident. Now, when you get the referral from accident and emergency, as the medicine doctor, it's your job now to really assess what it is they telling. So they were convinced it's a stroke, and they were already um their recommendation was once, CT comes back either for blood pressure control if it's hemorrhagic or dual antiplatelet therapy with Simlo and Omez if it's ischemic stroke. So they already write up this recommended plan. So you receiving that, you're gonna think, well, all right, I have to just follow suit because the accident and emergency doctor saw this, the consultant would have screened it before they sent it to you as the clinician. Um, but I wasn't convinced. I wasn't convinced. She didn't present like a classical cerebrovascular accident. And when I spoke to her, she was alert enough, oriented enough. And the weakness wasn't necessarily unilateral. She had a 4 or 4 minus on 5 throughout all limbs. So when I examined her, I recognized she was very, very stiff, very, very rigid. And I was like, this is not a stroke. She's very, very rigid. So there, and I thinking, what's going on here? Now I already know something is wrong with the accident and emergency referral because they suggested, or sorry, their impression was microcytic anemia for investigation. And I'm there like, sorry, not microcytic, normocytic anemia for investigation. And I there like, but how it could be for investigation is like they didn't even take into account she had a history of multiple myeloma. So that alone had me thinking, all right, this is a sketch referral. Cannot go with their own impression. I have to start over from scratch and do this whole workup for myself. So lo and behold, I was like, what is this going on here with this lady? Anyone has any thoughts? What might be going on with this lady? Real life. This was 2 o'clock this morning. Literally 2 o'clock this morning. Oh, that's a long thing to repeat, boy, William, boy. Um, Good. Okay, so our calcium levels were okay. Julian is on the right track. Something because of the medication, meningitis medication complications. Good. So the stiffness or rigidity wasn't. She had no nuchal rigidity. She had no features of meningism. Koenig's and Brzezinski signs were all negative. So it's not ruled out meningitis there, right? So it has to do with her medication. Her calcium level was okay. So remember, she has a history of multiple myeloma and Parkinsonism and L-DOPA, right? So there's a particular question we needed to ask her to cipher out this diagnosis. So it is a medication comp. Good, good. Almost thinking on the right track there, Brianna, right? So, yeah. So she didn't take her medication actually. So it wasn't wearing off phenomenon. It's that she stopped taking her medication altogether. And so this patient who was on L-DOPA with a sudden stop was worked up for a possible neuroleptic malignant syndrome. And when I called the registrar, I was like, Doc, I don't think this is a stroke. And she was like, what do you think it is? I say, it could be a NMS, neuroleptic malignant syndrome. And well, that was they were the accepting team, so I have to follow up and see if it was actually a neuroleptic malignant syndrome. I sent her for the CT scan because we wanted to rule out a stroke, but neuroleptic malignant syndrome could present just like that with fevers and confusion, altered mental status, and weakness, but is a rigid weakness. So in that case, that was very different to a cerebrovascular accident because the thing about neuroleptic malignant syndrome is they also have autonomic instability, and so they are at risk of many cardiac complications. When I saw the first ECG, she had a sinus tachycardia. When I repeated the ECG, she had a prolongation of the QT interval, and I was like, damn, this is probably really neuroleptic malignant syndrome. So we had to get her on continuous cardiac monitoring and so on. Yeah, so that's just my story to try and make sense of why call had to be call. I guess you don't really learn things like that unless you're on call, right? You don't really develop that critical thinking skill. So I just had to find ways to see where, okay, call was worth it, right? So, long story short, guys, remember as a clinician, as a doctor, always have your own thinking and mindset, and not because someone else says it's something, make sure you investigate the patient thoroughly and think about the case, look at the entire clinical picture. So I'll let you all know when we do neurology if it was neuroleptic malignant syndrome, if it was a stroke, what it was, because I'll find out later on today. All right, so that's my introduction there, trying to justify call and trying to justify being post call and having to teach post call when I could have just be teaching and not working in the people hospital, but then I wouldn't learn nothing, right? Cool. So good afternoon, everyone. Today's part two of GI. GI is extremely high yield. I can't stress that. Um, they ask a lot of questions on gastroenterology medicine, and of course, surgery is a lot of GI stuff as well. So on Saturday, please God, we'll be doing upper and lower GI. It's going to be a long class, so prepare for that because I'm doing everything in one class, and I'll probably start a little bit early as well. But it will have things that we didn't go through in full on Monday, like achalasia, cardia, esophageal carcinoma. Those things will be done on Saturday in even more detail from a surgical perspective, right? So today we're going to complete GI. We're going to do IBS, IBD, and the most high yield liver stuff. Okay. Thanks for doing the homework. Those of you who had sent it already. And remember, guys, make sure you do your homework and read through the guide because there are things that I wouldn't have been able to cover in class that would have been in the homework for supplementation. All right. So good thinking, by the way, everyone, and thanks for participating. So today, guys, please die in here. Please, like as much participation as possible, answer the questions, because like today is one of those particularly hard days to teach. So I'm gonna give it my best. Right, cool. So we're gonna get straight into it. Okay, so Jody sent me a direct message and I'll just read it out for you all. It says, Dr. Knight, I just wanted to say thanks so far for everything. It's been really helpful, especially for those of us who had IM and the clerkship exam this week. And I found a lot of what we've gone through came back on our written paper. So thank you, Jody, for that encouragement, right? But yeah, guys, so a lot of what we do, it'll come for end of clerkship, it'll come for MBBS. And more so, this is more tailored towards MBBS. When I went through the MBBS papers, I was like, yo, it seems like they kind of, I copy their questions or they copy my questions. I don't know what it is. So thank you so much, Judy. And to all of you who would have had exams, I hope you all excelled. I do believe that you would have. All right. So thanks, Judy. Okay, guys. So good afternoon. I'm going to start off with four questions. Sorry. I'm going to start off with four questions and then we'll teach. Right? So number seven, answers to number seven in the chat, please. Answers to number seven in the chat, please. Oh, you all see the screen, right? Just making sure. Okay, good. Yeah, answers to seven in the chat, please. I realize that you all take so much longer with the GI questions and everything else, and it cracks me up. was. I like, yo, was it 7 answers out of 70 what? Guys, I'm begging here. I'm begging. Okay, good, good, good. Seeing more answers. Right, cool, cool, cool. Great, great. Anyone wants to hazard this hazard, I guess, as to what is her most likely diagnosis? Yeah, good. Yeah, irritable bowel syndrome. So we need to know about some details about it, right? So because we have mixed answers, so that's good. We have some teaching points there. Very good. Thanks for answering, everyone. Keep up that same spirit, please. Many answers. It's very encouraging. Number 8, answers to number 8 in the chat, please. Answers to number 8 in the chat, please. Okay, good. Good. Thanks. Thanks. Right, we have done these questions last week. Right, number 10. Answers to number 10 in the chat, please. Answers to number 10 in the chat, please. Great. So this question is very, very similar to maybe as past question. What is this lesion called? Fantastic. Good. So we did one more question and then we'll teach. Okay. Number 14, right? So answers to number 14 in the chat, please. Answers to number 14 in the chat, please. Okay, good. So in this patient with ascites, um, what what score what score do we have to ascertain to determine whether or not it is due to portal hypertension? Excellent, good job. So I do ascites in great detail in OSCE because it's a common OSCE presentation, but there's 3 things you need to know about it for MCQ, right? A sag of less than 1.1 is not due to portal hypertension, right? So a sag of more than 1.1 is due to portal hypertension, right? So good. Right, thank you so much everyone for the participation. So please bear with me, guys. I do not have the voice projection today. My throat is extremely sore, so I'll be very calm and still enthusiastic, eh? Just not as loud. So that might even work out in your favor. Alright, so just pay attention, guys. Every single thing we do, as usual, is particularly high yield, but these topics, uh, IBS, IBD, SITs, and well, we're going to do the liver stuff afterwards, but these are the more commonly tested from an internal medicine perspective. The upper GI stuff is more commonly tested in surgery, okay? So let's pay close attention to every little detail. All right, good. Thanks for answering. Right, so let's see. Okay, great. You all see the screen? Right, see the guide. Nice, fantastic. Okay, so good day, everyone. Good afternoon. Welcome to part two of GI. Today we're gonna conclude our internal medicine teachings on gastroenterology as particularly high yield, everything is very commonly tested subdiscipline. A lot of questions are going to come on it. So make sure you know everything. This aspect of my teaching is one of the more comprehensive. Certain things I do in near completion, that is GI, endocrine, cardiovascular rheumatology. Certain things I have a little gaps for you all to fill in because it's so vast. So things like neuro is a lot more vast than everything else, but GI is pretty comprehensive. Most of what you're going to get tested on will be in our classes, in our guide, in our questions, the combination of it, and of course, study on your own, right? So today, the first topic we're going to do is irritable bowel syndrome. And I want you all to know about irritable bowel syndrome. So we can start right one time. We're going to do IBS, which means irritable, irritable. Think about that word bowel syndrome and think about this word, irritable and syndrome. I want you all to remember that irritable means pain. It's a pain syndrome. So it is primarily an issue of pain. It is primarily an issue of abdominal pain. Okay? So this is the main feature in irritable bowel syndrome that helps distinguish it from things like inflammatory bowel disease and celiac disease. So irritable bowel syndrome, just think about abdominal pain. This abdominal pain is related to and usually relieved by defecation. Okay, so relieved by passing stool, that is irritable bowel syndrome until proven otherwise. All right. So irritable bowel syndrome, a pain syndrome more than anything else. And because irritable bowel syndrome is a pain syndrome, I want you all to remember that there are no real systemic features. So irritable bowel syndrome does not have weight loss, right? It is not a syndrome of absorption, so it does not have malabsorption. Therefore, malabsorption, right? So no malabsorption, right? And the stool is never bloody. All it is pain. It's not inflammation. It's irritability. It is never bloody. So therefore, you can never have a lactoferrin. And a big distinguishing factor from inflammatory bowel disease for irritable bowel syndrome, you can never have what we call a fecal calprotectin. So fecal calprotectin in irritable bowel syndrome is negative. All right? Fecal calprotectin is a marker of inflammatory bowel disease. Irritable bowel syndrome, negative calprotectin, negative lactoferrin in our stool. Remember our stool studies from Monday. So lactoferrin is a marker of white blood cells, suggestive of infectious pathology leading to diarrhea, and calprotectin is positive in inflammatory bowel disease. So in irritable bowel syndrome, a pain syndrome, you have no weight loss, no malabsorption, the stool is never bloody, so therefore you have no lactoferrin. And to help distinguish irritable pain syndrome from inflammatory bowel disease, In irritable bowel syndrome, your calprotectin is negative. All right. So please take note of that. That is particularly high yield, and we'll see how we correlate them for, sorry, when we do inflammatory bowel disease. Okay. So irritable bowel syndrome is a pain syndrome. And just to further clarify so that you remember irritable bowel syndrome, guys, the way that it happens is due to a couple of things, right? It's due to hypersensitivity. What's the word here? I want to say visceral hypersensitivity. So visceral hypersensitivity. What that means is the patient, so this is your bowel, right? This is your bowel. And certain foods, particularly carbohydrates, so irritable bowel syndrome is triggered by carbohydrates. Certain foods, like carbohydrates, what they do is they draw water into the lumen. So H2O is drawn into the lumen. And what that H2 being drawn into the lumen does is that it stretches out the bowel. So when it stretches out the bowel, these pain receptors go to the brain. This is a brain, and it triggers this hypersensitivity response to cause pain. So, irritable bowel syndrome triggered by eating carbohydrates. Carbohydrates cause water to be absorbed, drawn into the lumen, stretches out the bowel. So, what makes this hypersensitive? The viscera, that makes it more, because in a normal patient, in a normal person, when you eat a lot of carbohydrates, yes, you draw water in, but because your visceral or receptors are not as sensitive, you don't really get pain, right? In a irritable bowel syndrome, these patients they usually have underlying psychiatric disease, right? And so therefore their whole neurocognitive function is a little bit dismayed. And the two common ones that it's associated with would be fibromyalgia, which is also a pain syndrome, and then any anxiety or depression syndromes. Okay? So particularly high yield about irritable bowel syndrome is that it is associated with psychiatric comorbidities. Now it is real pain that the patient is experiencing, but it is compounded and worsened by psychiatric perceptions of pain as well. So that's one way in which irritable bowel syndrome happens due to hypersensitive um, viscera. Okay. The other ways have to do with altered microbacteria and so on, and also hypermotility leading to diarrhea. All right. So that's irritable bowel syndrome, and we know everything about irritable bowel syndrome except for the last thing, which is our room 4 criteria. Okay. So for irritable bowel syndrome, it is a pain syndrome characterized by chronic abdominal pain relieved by bowel movements. It is more common in women than men. That's irritable bowel syndrome and associated with psychiatric comorbidities. Things like a history of sexual assault are to look out for. I've seen this in many USMLE type questions, right? Now it is a diagnosis of exclusion. Because it is pain, because it's chronic, usually chronic pain and chronic diarrhea, that's why we do the fecal calprotectin. Calprotectin is positive in IBD, in inflammatory bowel disease, but is negative in irritable bowel syndrome. So any patient who has irritable bowel syndrome, we have to work up and fully exclude all other diagnoses, right? So everything else is negative. It's just a pain syndrome. And therefore, to diagnose irritable bowel syndrome, you guys need to implant this in your mind. This is called the room 4 diagnostic criteria. It is very specific and particular to IBS. The patient ought to have recurrent abdominal pain at least 1 day a week for the last 3 months with two or more of the following. It's related to defecation. You have a change in the frequency or a change in the form of stool. So usually the patient would have severe abdominal pain relieved by defecation. And in terms of frequency, irritable bowel syndrome, and I want you all to remember this as well because I think most of you all got this answer wrong. Irritable bowel syndrome has three types. You have IBS-D, IBS-C, and IBS-M, right? And the D is for irritable bowel syndrome, where the bowel habits are usually diarrhea. And yes, by far, this is the most common way it presents. But the C is for irritable bowel syndrome associated with constipation. All right, so this is also common. So patients with irritable bowel syndrome can also have the C type, which is irritable bowel syndrome with constipation as the predominant bowel pattern. And then IBS mixed is well a mix of diarrhea and constipation. So irritable bowel syndrome commonly also can present with constipation, though it usually presents with diarrhea. It also presents with constipation. All right. So that is particularly high because I think most of you all got this one wrong. So the patient can have chronic diarrhea or constipation. It's associated with a change in the frequency and a change in the form of stool. So that means it can be either too much stool, too loose, too much stool that is loose, or it could be too little stool that is hard and pellet-like. So it can be constipation or diarrhea. The most important thing is that the belly pain, regardless of if it's constipation or if it's diarrhea, the abdominal pain, which is the primary feature of irritable bowel syndrome, is relieved with defecation. All right. So that is irritable bowel syndrome. And so how would we treat IBS? I have two of these things up. So how would we, sorry guys. How would we treat irritable bowel syndrome? I don't think I have this on the slides. So, well, obviously, you want to avoid the triggers, right? So you're avoiding carbs. And there's this diet called I believe it's FODMAP. Don't really need to know this. But there's the FODMAP diet that is preserved or reserved for IBS patients. So one is to avoid triggers, right? But then we have to treat the pain. This is particularly high yield. We have to also um, think about the bowel habits. So it could be constipation or it could be diarrhea. So we treat them either one. So if it's diarrhea, you give them some Lumotil. So we can treat them loperamide. If it's constipation, we give them some laxatives, right? Polyethylene glycol, etc. For the abdominal pain, we can use antispasmodics, and the drugs of choice would be how do you spell this boy? I think it's dicyclomine, um, or you could use tricyclic antidepressants. So the tricyclic antidepressants actually decrease the hypersensitivity, so they don't have this hypersensitivity response to pain. The dicyclomine is antispasmodic, so they have less bowel contractions and less pain. So we treat any pain with dicyclomine or TCAs, treating the underlying bowel pattern accordingly. All right. But the most important thing about IBS, more than treatment for you guys, is actually the way it presents and the criteria. Cool. So that's IBS. Everything you need to know about irritable bowel syndrome there. You need to know nothing else. So you don't need to read anywhere else once you have all those things. Any questions on irritable bowel syndrome, guys? We clear on that? There? All right. I know I'm not as loud and vibrant, so that's bear with me, right? Y'all okay? Y'all okay with me talking like this? It's okay? Yeah? Probably preferred because I'm always so loud in the air, right? I like to be loud because I'm very passionate. Okay, guys. So once no questions on IBS, we're gonna move on to the next topic. For the diarrhea, Sarah would be loperamide. Yeah, and if I take alumotil, well, yeah, alumotil in Jamaica. Loperamide, right? Loperamide, no problems there. No problems, right? So loperamide. Good. So the next topic, so that's irritable bowel syndrome, not to ever be confused with inflammatory bowel disease, which we're going with next. So remember all of these things and you know everything about irritable bowel syndrome. Now is this big bad boy, which is called inflammatory bowel disease. And I've actually got to teach this how I want it, kind of like pleural effusion. So the fact that I can draw makes this a lot more exciting. So inflammatory bowel disease, guys. Inflammation, right? Inflammation means systemic, means fevers and so on, means weight loss and so on. So that is not irritable bowel syndrome. This is inflammatory bowel disease and it's autoimmune in nature. The underlying pathophysiology is um, too much to go into, but it has to do with your T helper cells and your immune regulation with um, TNF alpha as well as the interleukins and so on. I'm not going to go into that. I'm going to go into what you need to know, right? So once we're thinking about a patient with inflammatory bowel disease, You have to think about the classic presentation, and I'll go through and I'll draw it out for each one, right? But particularly high yield, I want you all to know for inflammatory bowel disease, fecal calprotectin is the stool marker of choice. Once it is positive, it is highly suggestive of IBD. If it is a negative, it rules out IBD in most cases. All right. Patients could also have high fecal fat, steatorrhea because of malabsorption. It is a malabsorptive condition, especially Crohn's disease, and we'll go into that a little bit. They can have lactoferrin because it predisposes them to inflammation and GI tract infections. We will rule out other causes of diarrhea, however, like parasites and bacteria and C. diff. So these things help rule out other causes of diarrhea. But remember, when we were speaking about diarrhea, in those cases, it would have been a more acute diarrhea. These patients present with a chronic history of diarrhea, right? A chronic history of diarrhea associated with weight loss in ulcerative case, bloody stools, and so on. Less commonly in Crohn's would you have bloody stools, hardly ever, but we'll talk about it when we go into detail. But I want to point out on this slide, fecal calprotectin as suggestive of IBD. That is particularly high yield. Please write that down, right? So now let's talk about inflammatory bowel disease. So that's IBD. IBD. And the first one we'll talk about here is Crohn's disease. So Crohn's disease. So Crohn's disease, if we were to draw our, let's say, this is our bowel here. Right, this part here is your rectum, this is our anus. This would be somewhere here, would be our sigmoid here. This would be sigmoid. This is your rectum. So rectum, sigmoid. This would be our descending colon, our transverse colon, our ascending colon. Somewhere around here would be the cecum, right? And here, let me just draw this in yellow. I want this here to be particular. This is our small bowel, particularly the terminal ileum, right? So guys, we're talking here about Crohn's disease. What I want you all to understand about Crohn's disease is how it happens. Now, Crohn's disease happens like this. This is a transmural inflammation that happens like this in a skip pattern, skip lesion pattern. And I want to particularly highlight this, the terminal ileum. So first and foremost, what I need to understand about Crohn's disease is the most common affected site is your terminal ileum in Crohn's disease. I want you to understand for Crohn's, it can affect from the mouth to the anus. It is throughout the entire gastrointestinal tract, but it skips along the way. So that's why we have it in this manner, where it is skip lesions. So it skips along the way throughout the entire intestinal tract from the mouth all the way to the anus. The most common part is the terminal ileum, but even though it is from the mouth to the anus, the rectum is often spared from Crohn's disease. It is often spared. Can be involved because it can happen anywhere, but it hardly involves the rectum. And so for that reason, this explains everything you need to know about Crohn's disease in terms of how it presents. Now, the classic presentation of IBD would be, I'm putting it here, a young, Y for young, to middle-aged female with a chronic history of abdominal pain, fever, weight loss as the baseline. But to help distinguish Crohn's from ulcerative, it's a young female with abdominal pain, fever, weight loss, right? This is chronic, meaning it's more than 6 months going on, more than 3 to 6 months, she's having these bouts. And usually it happens in flares. But for the Crohn's recognition, the other symptoms is, so because it involves the terminal ileum, the patient will have the right lower quadrant pain because this is where you would have the terminal ileum connecting to the cecum. So right lower quadrant pain is one thing about Crohn's, right? These patients tend to have a diarrhea as well, But because your rectum is spared, it is often a non-bloody diarrhea in Crohn's disease. All right. So Crohn's tends to present in a young female with a chronic history of abdominal pain, fever, weight loss, right lower quadrant pain, and her diarrhea is non-bloody. All right. So that's usually the presentation of Crohn's disease. Now, remember, we said that there's skip lesions. So, what I want to tell you about Crohn's disease as well, right? What I want to tell you about Crohn's disease is the colonoscopy findings. So, the colonoscopy, I should say ileocolonoscopy. So, for Crohn's disease, this is the gold standard of diagnosis, ileocolonoscopy plus biopsy, right? So what you'll see on the colonoscope for Crohn's disease is we just said, look at the pattern here, right? You'll see lesions skipping across. So you'll see skip lesions on colonoscopy. The other thing that you'll see is a cobblestone appearance. And the reason I went from wall to wall is to say that you notice it's transmural inflammation. Transmural inflammation, right? And when you take the biopsy for Crohn's disease, this kind of inflammatory pattern has what we call non-caseating granulomas. Can anyone tell me what respiratory condition presents with non-caseating granulomas as well? Sarcoidosis, excellent. You're all studying fantastic, right? So when we working up Crohn's disease, so yeah, I'll just play the chat making sure, yeah. Sarcoidosis, that's correct, excellent. So um, when we working up Crohn's disease, if you want the gold standard, it's not just a colonoscopy, it's a ileocolonoscopy. We need to visualize the terminal ileum. And so when we look at that, what we're going to see on scope, on GI scope, we'll see skip lesions, the cobblestoning, and transmural inflammation. And when we take the biopsy, the hallmark feature is non-caseating granulomas. And that is particularly high yield for Crohn's disease. Remember, I told you need to know it for celiac, you need to know the pathology. For celiac, we said it was villous atrophy, crypt hyperplasia, and increased intraepithelial white blood cells. I went Remember, I told you that I always forget celiac disease. So for the past 3 days, from Monday to now, I went back and had to insert in my mind the third thing because I always remember crypt hyperplasia and I always remember um, villus atrophy, sorry, but I always forget intraepithelial white blood cells. So every single day I went back and looked at it, and now I remember it and will never forget it, right? But For Crohn's disease, you also need to know the pathology findings, which is non-caseating granulomas. So that's one aspect of pathology that comes for MBBS. Okay, so that is the workup and diagnosis of Crohn's. The other thing about Crohn's disease that you need to know, of course, would be for Crohn's disease, the autoantibody for Crohn's. So remember, C and S in Crohn's is ASCA, right? And ASCA stands for anti-Saccharomyces cerevisiae antibodies. And I reiterate, everyone, please learn all of your antibodies, their associated conditions, and learn what they stand for, because many times they also spell out the antibodies. So ASCA is positive in Crohn's. So it is ASCA positive. This is suggestive of Crohn's. All right. So that's the autoantibody for Crohn's disease. So we did the scope findings. We did the pathology biopsy. We know how they present with a young female abdo pain, fever, weight loss, and non-bloody diarrhea, but because it affects the terminal ileum, she'll have right lower quadrant pain, right? We said that on scope, you'll see skip lesions, cobblestone, and transmural ulceration. Pathology is non-caseating granulomas, and autoantibodies ASCA positive. So that's in terms of your workup of Crohn's, all right? So that's what you need to know. The other thing we need to know about Crohn's is the complications of Crohn's disease. So the complications. Okay, so there are three complications that relate to what that the underlying reasons for the for the manifestations of the complications. The first one is malabsorption. The second one is fistula formation, and the third one is strictures. Okay, so these are the three main complications of Crohn's disease. Now, the malabsorption, so we'll now, okay, so I'll kind of erase this now, so you'll have it in your mind, right? And let me just, oh gosh, just write over what we do, which is Crohn's. So if you're gonna take a picture, whatever. Now the complications we said is malabsorption as one. I want you all to remember this. This is very interesting. In Crohn's disease, it affects the terminal ileum, right? But it could also affect the entire small bowel. So one of the things that can be malabsorbed is fat. And if you have fat malabsorption, you have the reductions in your fat-soluble vitamins because you need fat to absorb vitamins A, D, E, and K. So patients could have vitamin A deficiency where they have eye problems or color blindness or what have you. Vitamin D deficiency would lead to like a hypocalcemia. Vitamin E with face skin and stuff. And vitamin K deficiency most commonly presents as thrombo uh, coagulation disorders, so to bleeding, right? So they have vitamin deficiency because of the fat malabsorption. They also have steatorrhea, right? So their stools will be very greasy. So you cover in between greasy stools because the fat is going into the stool. And this is particularly high yield here because complication of Crohn's disease that you'll commonly see is kidney stones. How the hell does Crohn's disease cause kidney stones? Well, because of the fat malabsorption, this fat, this yellow fat, is responsible for binding this green thing called oxalate. But if you have no fat, you have increased buildup of oxalate because you have no fat to bind the oxalate. This oxalate then goes into the kidneys and it leads to nephrolithiasis. So if they want to ask you why Crohn's disease have kidney stones, this is why, because of fat malabsorption and increased oxalate buildup. And so the most common stone would be a calcium oxalate stone. When we do urology, yes, the types of stones are critical and important to know all the features of them in terms of urinary tract stones. So malabsorption of fat leads to vitamin deficiency, it leads to steatorrhea, and it leads to nephrolithiasis or kidney stones, and that's how, right? So that's one complication. The other malabsorption is that of it affects where? The terminal ileum. I'll go back to black. The other thing is B12. So I want you all to always remember in terms of Crohn's versus ulcerative colitis. Now, you can affect the duodenum and have iron deficiency, but in your MCQ stem, look out for a macrocytic anemia, right? So a high MCV suggestive of B12 deficiency because Crohn's most common site is the terminal ileum, which is the site of B12 absorption. In Crohn's, you have higher chances of presenting with a B12 deficiency macrocytic anemia type picture. So look out for that in the question stem. And the last malabsorption is that of bile salts. So you can't absorb your bile salts. And if you can't absorb bile salts, what happens if you can't absorb bile salts? You can't absorb bile salts. Can anyone tell me what I'm about to draw? Whose triangle is this? Nah, not Shaku's triangle here. Good try though. Shaku's triad. But I'm saying triangle. Whose triangle is this? I'm gonna put bile here. I'm gonna put cholesterol here. Great, great, great. And I'm gonna put lecithin somewhere around here. That's the word. So remember your Admiron small triangle for gallstone formation. So if you reduce your bile salts, what happens? You have high levels of cholesterol. So in Crohn's disease, you have high cholesterol gallstones. Okay, so that is particularly high yield for Crohn's disease because you have no absorption of your bile salts. So I'll just write it back for you all after, right? So no study it, I'll write it back so you all could see it properly. Good. So that is Crohn's disease. One complication, malabsorption. So you have fat malabsorption, which would lead to steatorrhea, vitamin deficiency, and kidney stones because of increased oxalate. You have B12 malabsorption leading to macrocytic anemia. And you have bile acid malabsorption leading to increased cholesterol, gallstone formation. The other thing in Crohn's is I drew Crohn's and I said it happens like this, right? I drew it like this because Crohn's is transmural. So what that means is if you have transmural inflammation, this transmural inflammation could now extend and form a tract called a fistula. So fistula are not seen in ulcerative colitis, they are only seen in Crohn's disease. So one fistula could lead, could form, the tract could form, um, you could have fistulization, sorry, into the bladder, right? And this is what you call a polo, or I should say entero, because it doesn't have to be the colon, enterovesical fistula. Can anyone tell me how an enterovesical fistula will present? This is seen in diverticular disease as well, not so? So you all should know. Mm-hmm. So fecal urea, and what else? Flatus? Nah, not flatus. Flatus is wind without a back passage. But remember the bowel. So what's going to happen? This is the bowel seeping through the fistula. You have stool going there. What else you have in gas? Yep, you have air. So you have intervesical fistula presenting with fecoluria. I don't know how to spell this. It says fecal or fecal urea. And very importantly is pneumaturia. Right? And the patient will have repeated UTIs. So fistula seen in Crohn's, one fistula is with the bladder. So the other fistula could be with the skin, with the bowel. So you can have an enteric fistula. Someone's asking something. Right, pneumatria. Good, good. Right, enteric fistula. So that means the bowel. So two loops of bowel are going to fistulize together. Right. So what you have happening is things will, the stool will pass and this will lead to diarrhea with malabsorption. Right. So that's how your enteric fistula will present. But high yield is this thing here, which is your enterocutaneous. And this enterocutaneous fistula tends to happen around the anus. And so if you have a fistula with the skin around the anus, all the bacteria are going to build up around the anus, and this would lead to a perianal abscess. So Crohn's is a transmural infection, transmural inflammation, sorry, transmural inflammation. So it infects it infects, it causes inflammation of the entire wall, and therefore this could lead to fistulization. And the three types of fistula in Crohn's is enterovesical, which is the most common type of fistula, enteric and enterocutaneous. You could have perianal abscesses as a result of the enterocutaneous fistula. And the last complication of Crohn's is strictures. right? So that's Crohn's disease. So I'll just write it out for you. So you could probably take a picture. I don't know if I have everything on my guide. But just to note Crohn's disease complications, just to make sense of it. You have fat malabsorption. So it'll be fat. And we said you have reductions in vitamin A, D, E, and K. You have steatorrhea. And you have, of course, nephrolithiasis because we said why? Fat malabsorption means buildup of oxalate. So you have fat malabsorption, you have B12 malabsorption, which would present as a macrocytic anemia. And you have bile acid malabsorption, which leads to polylithiasis, which is gallstones. You have kidney stones and gallstones. These are complications of Crohn's, all right, because of the malabsorption, because of the location, most commonly being the terminal ileum. You also have fistula and abscess formation, and remember it is um, enterovesical, enterocutaneous, enteric. And when we reach diverticular, we'll see it C2V2, which is colocuticular, colocutaneous, colovesical, and colovaginal. But this is Crohn's, not diverticular, okay? And the last thing, of course, is strictures. Good. So any questions on Crohn's disease, guys? That is everything. I will talk about management of IBD separately. Are we clear on Crohn's? Absolutely. Feeling like because I'm not shouting, I'm feeling like you're not following along. You're all following along, right? And I'm boring you to death, right? Okay, good. Right, so let's just go through the thing and see, make sure we have all of that on our guide. So Crohn's is transmural inflammation all the way from the mouth to the anus. Non-continuous involvement means skip lesions. Most common site is the terminal ileum. Patient presents with chronic abdominal pain, weight loss, anorexia, low-grade fever. Right after ulceration, if it affects the mouth, that is particularly high yield. And please put non-bloody diarrhea, more common. They can have bloody diarrhea, but please put non-bloody diarrhea um, for Crohn's disease as being more common. Diagnosis is with ileocolonoscopy, and you have Cobble Skonin, skip lesions, and of course, the terminal ileum is involved. We have transmural inflammation can be seen. And when we do pathology for Crohn's, it's non-gaseating granulomas. We said it's ASCA positive, and the complications include strictures, fistula, which is colovesical, colocutaneous. You have abscess, and of course, there's an increased risk of colon cancer. And remember the malabsorption complications I didn't have on the slide, which is um, kidney stones, steatorrhea, and B12 deficiency. Okay, good, nice. So now we can do UC. So that's Crohn's. Now is ulcerative colitis. So for ulcerative colitis, remember the word colitis means colon. So for ulcerative colitis, I am not going to draw a terminal ileum. I'm just going to draw a colon. Okay, and I should probably just know. I was gonna say something probably inappropriate. I was gonna say I should probably make the rectum bigger. And I didn't know how that would have been perceived, and you'll go and report me and see how Dr. Knight is be saying kind of thing. But yeah, I should probably make the rectum bigger here. Right. So this is your rectum. Right. This is your sigmoid. This is your descending colon. This is your transverse colon. This is your ascending colon. Somewhere around here is your cecum. Right, and this is your anus. Good. Now, how ulcerative colitis happens, and I'll do this so you remember the image, is like this, right? So it's not transmural, but it is not skip, it is continuous, okay? So I'm doing it like this to highlight the point that is not transmural inflammation, it is submucosal inflammation. So it doesn't extend across the bowel wall, but it is in a continuous pattern, right? Is in a continuous pattern. So that's how ulcerative colitis happens. Now, very particularly how I feel about ulcerative colitis is its most common location. So the presentation is the same, young, female, abdo pain, weight loss, and fevers and so on. But for ulcerative colitis, the most common site affected is the rectum. So the rectum is most commonly affected, right? And because the rectum is most commonly affected, instead of the right lower quadrant being the pain, the patient will have left lower quadrant pain. Additionally, it's inflammation in the rectum, and so these patients would have the bloody diarrhea far more commonly than the Crohn's disease patients because the inflammation is in the rectum, close to the stool, right? So they have bloody diarrhea. This D is for the descending colon. And the last thing I want you all to remember is tenesmus. Can anyone define tenesmus for me? Tenesmus. Right. So it is not incomplete evacuation alone, it is the sensation, right? So it's a combination of all of your answers. So it's the sensation of incomplete evacuation. So it's the feeling that you always want to pass poop, even though your bowel is empty. So that's a particular definition you need to know because the surgeons ask about it for colorectal cancer. So look how common or look how similar this is to colorectal cancer. So a big differentiating factor would be your demographic population. Because I have seen an MCQ where this patient presented with LLQ pain, bloody diarrhea, tenesmus, alteration of bowel habits because she had constipation and diarrhea. But because it was a young female, middle-aged, with fevers as well, the more likely diagnosis in that patient was not CRC, it was ulcerative colitis. So make sure to look at the entire demographic. Remember, we said IBD happens in young, middle age. It happens in anyone, of course. It can happen in any old person, any old man, right? But I'm speaking about for question stems, they like to bring demographics to help differentiate factors, right? So look out for demographics. But this is how ulcerative colitis presents compared to Crohn's. Crohn's, you said, was right lower quadrant pain because it's terminal ileum. You said it was non-bloody diarrhea. All right? And the other thing I want you all to know about ulcerative as we hear is that smoking is protective, right? Smoking is protective for ulcerative colitis. It worsens Crohn's, right? It is protective for ulcerative colitis. That doesn't mean you tell a patient to smoke. It's just something to know that they like to ask a fact-based, right? It's protective against ulcerative colitis, right? So that's how Crohn's will present. And so because Crohn's is like that, when you do our workup for Crohn's, when we do our colonoscopy, which is the gold standard colonoscopy plus biopsy again, right? Because we really want to look at that. What we'll see on colonoscopy, excuse me, would be continuous lesions. The mucosa will be friable mucosa, right? So it's continuous ulceration with friable mucosa. When we take the biopsy, what we're going to notice on biopsy, it is submucosal inflammation, not transmural, submucosal inflammation, but high yield for ulcerative colitis is crypt abscesses. Okay, so it's submucosal with crypt abscesses, whereas for Crohn's it was transmural with not with non-caseating granulomas. For ulcerative colitis is submucosal with crypt abscesses. Colonoscopy would show your continuous lesions and your friable mucosa. All right, so that's how you diagnose UC, and then what therefore would be the antibody And the antibody, which I got wrong because I think it was Jody or somebody, not Jody, Brianna, or one of y'all. I remember somebody corrected me and let me know, hey, doc, no, it's P anchor because we said C anchor is Wegener's granulomatosis. So ulcerative colitis is P anchor positive, Crohn's is ASCA positive. So this is particularly high yield for ulcerative colitis. All right, it's P anchor positive. Good. And then the complications of UC are far easier to remember. Um, there's really only two you need to know. It's actual colitis, because colitis is inflammation of the colon. Yes, that presents this particular way. So this is using a flare. They'll have increased pain with fever. This is during the flare. They have an acute inflammation of the colon, increased white blood cell count, and increase in the hematochezia, right, which is your bloody diarrhea. Okay, so this is how colitis presents. This is one of the complications. But the issue with colitis is that if you have prolonged colitis, it can lead to this here, the inflammation. What it would do, it would decrease your motility. If you decrease motility, what's going to happen? You're going to increase your bowel. You're going to dilate the bowel. And a dilated bowel more than 6 centimeters plus the above symptoms equals what we call toxic megacolon. Okay, so the third complication of ulcerative colitis is that of toxic megacolon, which is where you have this prolonged colitis, pain, fever, white blood cells. That leads inflammation, reduces the motility of the bowel, and then the bowel starts to dilate, and it leads to what we call toxic megacolon. All right. So for ulcerative colitis, complications are colitis, which presents with increased abdominal pain, fever, increase in the white cell count, and increase. I just want to put PRB, but what we mean is blood in the stool, right? This now leads to what we call dilation of the bowel loops, and it needs to be very large, dilation more than 6 centimeters, which is toxic megacolon. When you have this, those symptoms plus dilation, dilated bowel loops. The issue with toxic megacolon is that if you have a bowel, it was like this, and then now your bowel is like this bowel could perforate. Okay, so you can have bowel perforation, and the third complication of toxic megacolon is peritonitis, and particularly a fecal and peritonitis. Okay, so toxic megacolon, colitis, and perforation and peritonitis are the complications of ulcerative colitis. Okay, so that's that. Good. Let's remember for IBD, that is both Crohn's and ulcerative colitis, you have an increased risk of colorectal carcinoma. All right. Of course, your risk of colorectal carcinoma will be increased if you have Crohn's affecting the large bowel. So it doesn't always do that. So therefore, ulcerative colitis has this greater risk, right? Because it affects the colon directly. So there's a greater risk of colorectal carcinoma in ulcerative colitis, but remember that Crohn's, all forms of IBD increase your risk of colorectal carcinoma. And so now here's my question. Patient has IBD. What are your guidelines for screening colonoscopy in patients with IBD? Because they have an increased risk of colorectal cancer, right? So what's your guidelines? Oh my gosh, guys, I'm struggling here. You all know or you don't know? Need me to tell you? Sure. Nah, so screening colonoscopy, right? Colonoscopy. The fit test is useful by asking particularly about when you would use a, how often would you do colonoscopy. So the guidelines once they diagnose a patient with IBD is 8 8 years after the symptom onset, you're going to start to screen them with colonoscopy, and you're going to do this every 1 to 3 years. Okay? So 8 years after the patients first started, so let's say they started experiencing symptoms at the age of 22, you are going to start screening colonoscopy at the age of 30, and you'll do that for the patient every 1 to 3 years. All right, so you could do it at 30, then 32, then 34, then 36, then 38, whatever. But it's 8 years after the first symptom onset. So that is particularly high yield. So all patients with IBD should have frequent colonoscopies 8 years after their symptoms would have begun. Good. The last couple things about IBD would be the extra. Oh, any questions on? I just want to go through this. Any questions on ulcerative colitis, guys? We clear? Clear, right? Okay, fantastic. So ulcerative colitis, let's see what we have on our guide here. It's colonic inflammation, usually starts in the rectum, so that's high yield. So that's why sure, William. You got on mute. Do we need to know true love and wits? You don't need to know the details of true love and wits, right? Um, Not for your exam, but it will help for you to go through the criteria and score. They're not gonna ask you. So things like wealth score, true love and wit score, you don't need to know like the actual, or they're not gonna ask you to calculate the scores. Glasgow Blatchford score for GI bleeds, Nicholls score. They're not gonna ask you to calculate it, but you should understand what these scores do and how it's interpreted. Yeah. Um, so yeah, ulcerative colitis. It's limited to the colon, and remember that it is mucosa and submucosa. It is not transmural, so therefore you cannot have fistulization in UC. You can only have fistula in Crohn's. It's continuous involvement. Most common site is the rectum. These patients tend to present with the bloody diarrhea, left lower quadrant pain, tenesmus, as well as the other symptoms. When we do a scope, we'll see continuous ulceration, fibrous mucosa. You can't see pseudopolyps. I think I left that out. Can't see pseudopolyps, and they are P anchor positive, right? P anchor stands for perinuclear antineutrophil cytoplastic or cytoplasmic, probably cytoplasmic, I don't know, antibodies. I probably misspelled this here, right? So know how to spell out all the antibodies, and crypt abscess is what is seen on your biopsy, all right? Good. The complications are toxic megacolon. You can have venous thromboembolism. That is particularly high yield. That's particularly high. You have an increased risk of venous thromboembolism in IBD, especially ulcerative colitis, because of the chronic inflammation. So chronic inflammation leads to a hypercoagulable state. All right. So just remember that you have an increased risk of venous thromboembolism in IBD as well. That's particularly high. Good. And the last couple of things would be the extraintestinal manifestations. Okay, so IBD extraintestinal manifestations. So how I remember it is by the joints. So for the joint manifestations, you have arthralgia, so they tend to have a lot of systemic things. Arthralgia, they tend to have a spondylitis, and they tend to have particularly high is sacroiliitis. I don't know how to spell this, right? But this is particularly high yield. So they have that. It affect the eyes, and the most common eye manifestation is a uveitis, right? They affect the skin. The most common skin manifestation would be pyoderma gangrenosum. And what's the other one, guys? What's the other skin manifestation? Erythema nodosum, fantastic, right? Erythema nodosum. And remember, I told y'all, remember to learn the difference between erythema nodosum, erythema migrans is seen where? Where do we see erythema migrans? What condition? Fantastic. Where do we see erythema marginatum? Right? Good rheumatic heart disease, right? Your Jones criteria. And well, erythema multiforme. is due to a whole host of things. You need to know all the drugs and so on that cause erythema multiforme and all the infections as well, right? And well, erythema nodosum is seen in sarcoidosis and so on, and this is the one on the shins. It's painful panniculitis on your shins. So it's painful red bumps because of inflammation of the subcutaneous fat. That is what a panniculitis is, right? And the last thing I want to point out here as extraintestinal is primary sclerosing cholangitis, which I'll talk about separately when we do liver stuff. And this is only seen in ulcerative colitis. Okay, so please write down primary sclerosing cholangitis is only seen in ulcerative colitis. And I want you to say that any patient with primary sclerosing cholangitis likely has ulcerative colitis. Any patient with ulcerative colitis might have PSC. But if you have PSC, your chances that you have UC are very high. All right, so that's that. Last thing for IBD would be the treatment. So the treatment of IBD. No one does really teach all of this. Now, I'm not a gastroenterologist, and this is a consultant call, but there are basic principles you need to know of. You need to know what are the induction agents. You need to know what are the maintenance agents. So the induction agents would be 5-ASA, which is mesalazine. You have steroids, and you have anti-TNF. Can anyone tell me what is the anti-TNF drug, the most common one? What's the name of this drug? Infliximab. Good. So infliximab. And what test do we have to do before giving a patient infliximab? This is a MCQ. Please write it down. What test must be done before starting infliximab? Or I should say, what must we rule out before starting infliximab? Excellent. We must rule out tuberculosis, so we'll do a man too. Okay, screening test. Good. So these are our induction agents, 5-ASA steroid and anti-TNF. Our maintenance agents will be 5-ASA, same same anti-TNF, but we also have anti-metabolites, and the anti-metabolites are 6-mercaptopurine and azathioprine, right? Those are the anti-metabolites. And then we have other things that are less commonly tested, but we have anti-interleukin 12, 23, and I think the last one is anti-integrins. Should I read this before I teach it? Right, but these last two here, right? These last two here are very, very like way beyond the scope of MBBS. So that's why I don't really remember them too well. Right? But I want you all to remember that the antimetabolites are maintenance agents. Shit. Right? And the steroids are induction agents only. Okay? So how do we treat ulcerative colitis and Crohn's disease? So they're very similarly treated. So for a mild to moderate flare, mild to moderate disease, what we're going to do is we're going to induction with either 5-ASA or budesonide, and then we will maintain with our anti-metabolites, which would be our 6-mercaptopurine or our azathioprine. So that's mild to moderate. For moderate to severe, we are going to induce again, but we are going to induce particularly with oral steroids and then maintain with 6-mercaptopurine or azathioprine plus anti-TNF, which is infliximab, plus or minus infliximab. So we add on the big bad boy for the moderate to severe. And if it is severe refractory Crohn's disease, we have to do IV steroids for induction plus anti-TNF for induction, which is infliximab. And then to maintain them, we have to keep them on the infliximab, but we also have to add on. We can add on one of the other two, which is an anti-interleukin. I forget the name of these drugs. Anti-integrin. This is plus or minus, or anti-interleukin. I can't remember the name of the drugs, guys. Right? This is beyond the scope. But the high yield point about the treatment of IBD is that for induction, you're gonna use salazine or budesonide. Particularly high yield about this. This is where your question might come. When it comes to Crohn's disease, right? 5-ASA is used if Crohn's affects the rectum. Budesonide is used when Crohn's affects the ileum. Why? Budesonide is a per-oral drug. It's an oral steroid. But 5-mesalazine or 5-ASA is a rectal drug. So if Crohn's disease affects the rectum, we use mesalazine. Oh my gosh, I don't know what to do there. I don't even know how to undo that. Oh my gosh. This thing is not there. I hope you all had pictures of that because I'm not writing it over. But high point, if Crohn's affects the
You
rectum,
see arrow on top on the left on the right hand side where you see the double arrow and it should come back. So you see in the curve arrows, right and left
yeah,
on
I'm
top.
trying to tap it. Yeah,
So
let's
the next one. Yeah, try that one then. Yeah, try backspacing it.
and
But
not doing anything.
not doing anything. Okay.
Damn, because I don't have that in my guide, because that's why I make you all come to this. Right? Um, try Control Z. Control Z. Nothing. Try undo. I don't know how the hell that happened. Oh my gosh. Okay, so I guess you all probably didn't have it. Pressure. Right? So what I could simply do is just send you all a picture in the group or something, right? Because I'm not gonna write over that again. But high yield about it is mild to moderate Crohn's disease. Um, affecting the colon, we would use mesalazine, which is 5-ASA. So colonic Crohn's, mild to moderate, right? We're gonna use 5-ASA because this drug is given, I should say rectal Crohn's. Because remember, Crohn's usually spares the rectum. But if the rectum is involved, we have to give this drug, which is administered rectally. But if it's just the old good old ileum that's affected, then we can go with our oral steroid, which is budesonide. Right? This is given to oral. But don't worry, don't stress the treatment thing. I'll write it out and send a pic in the group or something. Worry not. Just not feeling to go over that right now. Cool. Good. Alright guys, that's inflammatory bowel disease. Any questions on IBD? Are we clear? I know we had a little mess up there. I will send the treatment, but are we clear about UC, Crohn's, the pathology, the colonoscopy findings, the autoantibodies, the extraintestinal manifestations? We know that Crohn's is the one where we have kidney stones and gallstones for various reasons. We have B12 deficiency more common than iron deficiency. We know about ulcerative colitis being related to primary sclerosing cholangitis. We know about all of these things. Any questions on IBD or IBS, guys? Okay. Is that clear? Good. Last thing before we go back answer the questions and take a break. Everybody clear, right? Any little feedback, guys? Thanks, thanks. Alright, cool. The last thing before we move on is ascites. Right? Now we're gonna do liver stuff, and ascites is commonly due. Excuse me. What is these? It's not coming. Okay. Ascites is commonly due to portal hypertension. But if a patient has ascites, what you're gonna do is you're gonna do it's a paracentesis. Now you have paracentesis of the eye as well. So the more accurate term is para yeah, paratoniocentesis or pericentesis. One of that, right? Anyways, what you're gonna do? You're gonna do acidic fluid tap. All that this means is acidic fluid tap. Okay? Fluid tap. It's also called a paracentesis, but I know we have paracentesis of the eye. So I just say acidic fluid tap. Paracentesis or periocentesis, whatever you want to call it. Once the patient has ascites, you're gonna have to tap them. In most cases for your MCQs I'm talking about. In real life, people have ascites, they live in. When ascites comes for your OSCE, as it usually does, I need you all to remember that the most specific clinical finding of ascites is not a fluid trill. Shifting dullness is the clinical diagnostic tool for ascites. Okay, so this is high yield. This question was asked to me in my exam. All right, so shifting nullness is very specific to ascites. The reason you can't use fluid thrills is because you need more than a liter of fluid to actually get a thrill, right? But shifting dullness is particularly specific, and the gold standard clinical way to say this is ascites. Of course, you'll want to do abdominal ultrasound to see the fluid, all right? But that being said, what you need to know about ascites is just these things here from an MCQ perspective. So for ascites, you do a plural tap. What you're going to have to do is calculate the SAG score, which you're familiar with. SAG stands for serum acidic albumin gradient. What it is the serum albumin minus, that is not over. I should see put this here. So the serum albumin minus the acidic fluid albumin. Right? So it's kind of similar in terms of like a pleural effusion, or you have to do a tap and then calculate some sort of score and whatever to determine if it's a transudate or exudate. So SAG score calculated by the serum albumin minus the acidic fluid albumin. What you need to know about this is a SAG score of greater than 1.1 is ascites due to portal hypertension. Right? A SAG score. So now let's list out these causes here. So a SAG more than 1.1 is due to portal hypertension. And so the causes here would be the things that cause portal hypertension, right? So that'll be cirrhosis, heart failure, um, particularly right-sided heart failure, Budd-Chiari syndrome, right? Budd-Chiari syndrome is where you have a clot in the hepatic portal veins or plain old portal vein thrombosis. So all of these will increase your venous pressure, your portal venous pressure, and lead to portal hypertension. So a SAG score of more than 1.1 means that your ascites is due to a cause of portal hypertension, and these are the four. That's one. So take a picture of that if you need to. Right? Good. When a SAG score of less than 1.1, that means it is not due. Less than 1.1 is not due to portal hypertension. And in this case, it is due to infection, inflammation, malignancy, commonly TB as the infection, inflammation, commonly pancreatitis, and the malignancy could be peritoneal cancers. So very much like pleural effusion where you have an exudate. right? So that's a SAC score of less than 1.1. It is not, the ascites is not due to portal hypertension, it is due to of these causes. Oh, and the last one, nephrotic syndrome, right? So that's a SAC of less than 1.1. What else you need to know about ascites, guys? And this closes our teaching before we take a break, is the diagnosis and workup of this thing called spontaneous bacterial peritonitis. So this is basically in patients with cirrhosis, they have ascites and they develop an infection because of the ascites in the setting of ascites. So this would present with severe abdominal pain. Of course, the patient has ascites, which is worsening. So worsening ascites, the patient will be very sick with fevers, and they may also have some element of hepatic encephalopathy as well, right? And so for spontaneous bacterial peritonitis, what we have to do, this is an emergency with a very, very high risk of mortality. And so we have to diagnose this very quickly. And so when we do our aesthetic tap, what we'll see, what will you see, guys? On a aesthetic tap to tell us spontaneous bacterial peritonitis. I'm asking you all. You all know? Or you all don't know? But yeah, a neutrophil count more than 250. Or sometimes you might see it as polymorphonuclear. This is the same thing as neutrophils, right? Greater than 250. This is particularly high yield, high yield. Now, a polymorphonuclear count of more than 500 is more specific, but because a polymorphonuclear count of more than 250 is more sensitive, this is the threshold we use. And the difference between the specificity and the sensitivity is very minimal. So a PMN count of more than 500 is 98% specific, but it's 86% sensitive. But a PMN count of more than 250 is 94% specific, but 94% sensitive as well. So because it has a higher sensitivity, meaning it is more likely to detect and diagnose SBP, this is why a polymorphonuclear count of more than 250 is what we use, right? Not 500. It's more than 250. And they will put that to trick you. Now, if they ask you which is more specific, which is the most specific way of diagnosing SBP, it is a PMN of more than 500, but it is not the best way. It is the most specific. This is the best way because of a greater sensitivity. All right, so just be careful. I don't think that they will trick you like that. That is very high, like distinction type question. But because it is a distinction type question, they can ask you. The most specific way is a polymorph nuclear more than 500. But the best way and the more sensitive way and the way that we will learn to diagnose spontaneous bacterial peritonitis is a neutrophil count of more than 250. All right? And so in all patients with spontaneous bacterial peritonitis, we have to know how to treat them, and we treat them empirically, immediate empiric treatment until we get back cultures and so on, with a third generation cephalosporin. The preferred one is actually intravenous cefotaxime. I believe this would be, you can check this, but I think it's 2 grams because we had a patient with with SBP, but we don't have cefotaxime in hospital, so we give them ceftriaxone 2 grams every 8 hours. So I think this is the same for cefotaxime, but you all can check up that and verify, right? But you have to give them empiric treatment with a third generation cephalosporin, preferably IV cefotaxime. All right, and that's everything you need to know for my MCQ point for ascites. Good. Any questions on ascites, IBD, or IBS, guys? Crohn's or ulcerative colitis. Are we clear on all of that? Thanks, Christina. Is everyone clear? Sorry, guys. Sorry for. Promise you I'm loving this class. I promise you I'm enthusiastic. I promise. I love you all. All right, good. So let's just clear up our board here. I like this. I like this. First time I got to teach you IBD like I wanted to. I think it was well received. So no, you just minimize this here. Good. Nice. So now we can answer our very first question, which most of you all got wrong. Good. So number 7 answers in the chat, please. I want as many as possible, please. Right, excellent. So recognizing this pattern is important. This is irritable bowel syndrome. Young female, history of crampy abdominal pain with diarrhea. The pain comes and goes, but is present most of the day. Pain alleviated once she defecates. So abdominal pain with diarrhea, alleviated, and the pain relieved by defecation. She has the IBS diarrhea type because she has more than 5 loose stools per day. She has no weight loss. She has no fevers. She has no history of recent travel or camping to suggest an infectious cause of her diarrhea. Her past medical history is that of psychiatry, so it's generalized anxiety disorder. She's been adequately treated with sertraline for the past 2 years. So this is not serotonin syndrome. Why I want you all to do the homework is because I have an answer sheet, and in the answer sheet I have for one of this same type of question. I have what you need to know about serotonin syndrome. So please do the homework. Stool testing is negative for fecal calprotectin. We said fecal calprotectin is positive in inflammatory bowel disease, not irritable bowel syndrome. So, given that her most likely diagnosis is IBS, irritable bowel syndrome, which of the following is true? Well, A is false. It does not cause bloody diarrhea. B is false. There is no malabsorption. It's a pain syndrome. And D is also false. Lactoferrin is only seen in infectious causes of diarrhea. So, this condition, irritable bowel syndrome, also presents with constipation in the IBS C type as well as the IBS mixed type. So, C is the correct answer. Excellent, everyone. Number number 8. Let me get just what is this patient's most likely diagnosis? Ulcerative colitis. More likely, she's a 34-year-old female with bloody diarrhea. She has belly pain and bloating, but her diarrhea is bloody, very high yield. This going on for 6 months, so it's chronic bloody diarrhea with belly pain and vomiting. She has a family history of bowel cancer, meaning that she probably has IBD in her family, with increased risk of colorectal cancer in her family as well, and a recent onset of weight loss. She was previously well, however. She's thin with pale mucous membranes, so this could very well be colorectal cancer straight away. But because she's 34-year-old, she's female, she's this acute onset for 6 months with this chronic picture of bloody diarrhea and so on. This is more likely to be UC rather than CRC. There's more likely to be ulcerative colitis. She has a microcytic anemia with a normal white cell count, indicating is unlikely due to infection but more likely due to inflammation. Her microcytic anemia is likely because of her blood loss in the diarrhea. Colonoscopy confirms it because we see a uniform pattern of inflammation, and it's restricted to the rectum and sigmoid colon, right? So we've ruled out bowel cancer altogether. So there's no risk of colorectal cancer is wrong. This is ulcerative colitis. Serology, serology testing is likely to be positive for ASCA. No, that is positive in Crohn's. The pathology is likely to reveal caseating granulomas. No, that is, well, caseating granulomas is seen in what? Tuberculosis, right? So that's not even remotely to do with IBD. It's non-caseating granulomas for Crohn's. Serology testing is likely to be positive. So where do we see anti-gliadin antibody? It's not UC. Where do we see anti-gliadin? Celiac. And what are the other two we see in celiac disease? Fantastic. So anti-TTG, anti-tissue transglutaminase, and anti-endomysial. Excellent. And remember that the anti-TTG is an IgE antibody, so you need to make sure that you have sufficient IgE levels before you test for the anti-TTG, even though the anti-TTG is the most specific and the best one to test. So E is also false considering this patient. So A, B, C, and E are wrong. So it does not spread proximal to the ileocecal valve. And I'm not sure if I mentioned it, but if you have a patient with ulcerative colitis, if you have a patient with ulcerative colitis, right, let's go to draw it here, right, ulcerative colitis, and this will be our terminal ileum. Ulcerative colitis is like this, right? It affects the colon only, but what could happen is in a patient where they have, this is called an ileocecal valve. So remember the normal passage, this is our ileum, right? So the normal passage of stool would be from an ileum or from food or digested material, ileum, ascending colon, well, cecum, ascending colon, transverse colon, rectum, and out through the anus. If a patient has an ileocecal valve that is incompetent, what could happen is you could have instead backflow, right? So you could have backflow. So in patients with an incompetent ileocecal valve, incompetent, I know that's not how that looks, but an incompetent ileocecal valve, these patients could have what we call a backwash ileitis. Backwash ileitis in ulcerative colitis. So that's the only way we will see anything close to being suggestive of the ileum being involved. Because remember, ulcerative colitis is usually restricted to the rectum and colon. But if they have an incompetent ileocecal valve, they can have backflow, preventing, so the valve is unable to prevent backflow, and so you have some inflammation backflowing. And that's the only way you'll have um, involvement of the ileum in UC. But in all other cases, for all intents and purposes, ulcerative colitis is restricted to the colon. And so D, it does not spread proximal to the ileocecal valve. Right, so good 46-year-old woman, pyoderma gangrenosum. She has a macrocytic anemia, right? So it says vitamin B12 probably. Her white cell is a little bit high because of this infection, inflammation type picture going on here. And she has this chronic illness. So you need to recognize pyoderma gangrenosum and know that it is associated with IBD. And out of all these options, pyoderma gangrenosum is most likely associated with Crohn's disease, and she also has the clinical picture of Crohn's disease. Well, the laboratory picture that is more likely in Crohn's. Remember, Crohn's could also cause IDA, so don't just see IDA and think it is not Crohn's, and don't just see macrocytic and think it is Crohn's, right? I'm just telling you how the question stems come. It's just more likely. And the last one was 14, and you all got it. Which of the following is a cause of ascites secondary to increased or portal hypertension? And we said that would be a SAG score of more than 1.1, which is seen in Budd-Chiari syndrome, heart failure, cirrhosis, and portal vein thrombosis. Tuberculosis, peritoneal cancer, pancreatitis, and nephrotic syndrome will all cause a SAG score of less than 1.1. They are not causes of ascites due to portal hypertension. Good. Fantastic. Everyone clear on those things? Any questions at all? Good. We clear on IBS, IBD, ascites, right? Went into such exquisite detail because you are going to get questions on IBD for sure. You might get one on IBS. I'm not too sure about the ascites, but remember about spontaneous bacterial peritonitis. That's particularly high. Right, guys? So good. So if no questions, thanks for your participation. We're going to take a break. We're going to start back at 8 o'clock and we're just going to blaze through all of our liver stuff. Liver is a big chunk of what is tested from an IM perspective. So we need to take a break, rehydrate. I need to drink some Gatorade, take two Panadol, and blaze through liver. All right. So I'll see you guys at 8 p.m. 8 o'clock we'll resume. All right, guys. Thanks for the bit of encouragement. Um, I did, I did teach a class sick for my last course, and I ended up not finishing because I was so sick. I was like, no, doctor, running joke now, doctor, I get so sick, blah blah. So I was wondering if to have this class today, but we don't really have much room for like rescheduling and stuff. And I actually am on in April. I am on. I have a day that I'll be on call. I'm on a Thursday. Yeah, Thursday that I'm on call. I might need to reschedule that class. So I'm gonna push on through. Thanks for the encouragement and thanks for participating and thanks for following along. Right? Mishak, you there, boy? Mishak? Okay, Mishak probably just logged in and stepped away. I saw Mishak recently. Um, he was he was brave and he was like, Dr. Knight. I was like, yeah, boy, what's up? I never saw him before in my life. I was like, who's this man calling me? Boy? I was like, yo. He's like, yo, my name is Mishak. I was like, yo, your name is Mishak. I know your name. Say, yeah, boy, Mishak Ramjit Singh. I said, yeah, you in my class. He said, yeah, I'm in the class. I was like, yeah, boy, that real cool. I was like, yo, because usually, yeah, boy. So, you want me free to unmute or you're shy or are you talking now?
No, no, it's just sorting out something quick.
Where's sorting out? Where's sorting out?
I was getting a snack.
Mishak. Where's he seen my some of that pediatrics thing teaching you, treating you?
It's okay.
You like it or?
Not really, but we'll go with it.
Alright, cool, cool. Thanks, Mishak, thanks. So yeah, because so yeah, that's happened, right? So like sometimes as we walking through Moncton and I have students and like the students probably know of my course or something and I probably have some students who are in my course who I see. And it actually happened on a couple occasions. And they'll be whispering and talking to the friends and thing. And I feel like a big superstar like Drake or one of them. Because I know they're talking about me. Because I see them glancing and plenty of times the girls and them and the girls and them will be smally. So like they're kind of shy. So a couple of students, like was a group of them in my last course, and they were in my course. But I'd never met them before, and I see them whispering and thing. I was like, I know they're talking about me, so I feel like a real superstar. But I like when you all come up to me and introduce yourselves in person because I was like, hey, now I could see our face to the name, and in the future, I could know that, hey, so we had this special connection at one point. When I see you become this big doctor, just don't forget me. Remember that you learned a lot in this course and stuff. So always never be scared to say hi or anything because I love my students, right? I really do cherish you all and I try to give my best for you all. Okay, so that's my talk for this evening, right? Cool. So let's go. We will do liver stuff. Now, guys, liver stuff, man, liver stuff is real high yield for I am, okay? So we're gonna start now. We have about 5 questions or so, and then we'll teach. So number 15, answers to number 15 in the chat, please. Answers to number 15 in the chat. You all seen the screen, right? Okay. Good. Number 16, easy question. Number 16, answers to number 16 in the chat. Good. What particular blood tests can be used to diagnose Wilson's disease? To aid in diagnosis, I should say, of Wilson's disease. Good. And what will be the ceruloplasmin levels? Low or high? Good. Excellent. Number 17. Answers to number 17 in the chat, please.